Thanks, Almudena, for joining today.
Hi, everyone.
Hi, Abhijit.
Hello.
Hi, Jano. Almudena, would you like to share your slides and just see if it's working?
Yes, I'm opening it.
Thank you.
Hi, Almudena. Sorry, now I have some sound. I can see. Sorry.
It is trying to open.
No worries. Because it probably has videos in it, it's just a bit slow. That's your first presentation for our group, so we're very excited to have you today. So that's really
Yes, and I'm very grateful.
Oh, thank you for
I've
your
been
time.
able to listen to some of your lectures, not always, sometimes on remote, and they're quite good.
Oh, thank you.
I would like to congratulate you because you're an example to follow.
Oh, thank you very much.
Can you see this?
Not yet.
No, I have to share, sorry. Now?
Yeah, fab. That's great. Maybe we'll give it another minute or two for more people to join, and then we can kick off.
Videos are not moving, probably due to... I'm gonna change my connection, my internet connection. Maybe I lose connection. Don't get panic.
Okay, we'll wait for you.
Okay.
Virginia, are you still on holiday? Thanks for joining today. You're mute.
Oh, you're on holiday. I can't hear you, Virginia.
Sorry,
yeah.
yes, I was skiing, so I'm going to blur the background of the
Where
chalet.
are you?
In the Pyrenees, not far from you, actually.
But in the French side?
Yeah, French side.
Okay.
Are you going there sometimes?
Yes, but to the Spanish side.
Yeah, of course. I think it's better. I think it's
No, it's just different. More sunny, maybe.
Yeah. Well, the first time I used to go to the Alps, but I think the Pyrenees was a good try this year. So good try.
I'm ready whenever you want.
Yeah, I think you can.
Yeah, we'll just welcome new colleagues joining us today. We've got Jano from Panama. We've got Dr. Harsh Gauda as well, who joined. I don't know if that's your first meeting, Harsha.
Yes, it's my first meeting. Thanks for the invitation. Thank you.
Lovely to have you. Lovely to have you today.
Hi.
Okay. Virginie, do you want to?
No, maybe it's too early because
Okay.
there's just 9 people connected.
Right. We'll be ready whenever you're ready. Almudena, do you want to try sharing again and make sure the videos are working?
Can you see the video moving? Okay.
Working nicely.
Mahmoud, I let you introducing Almudena maybe as
Okay.
we. Yeah.
So thank you everyone for joining today. We are very pleased to have Dr. Almudena Alonso talking to us today. Dr. Alonso is attending neonatologist at Hospital Puerta del Mar in Cadiz in Spain. Her PhD was about the usefulness of lung ultrasound in bronchopulmonary dysplasia. She has different publications of neonatal lung ultrasound, particularly in neonatal ultrasound and diaphragmatic ultrasound as well, mainly for the use of to monitor very preterm infants during their stay in neonatal intensive care units. She's also the coordinator of the Spanish group for the study of bronchopulmonary dysplasia using lung ultrasound, which includes more than 10 neonatal units. She is the coordinator of the respiratory section or in the focus group of the Spanish Society of Neonatology. Just to add to that, she's a very well-known name in the world of neonatal lung ultrasound. She's been teaching in many courses, national and international courses as well. So we're so pleased to have you today, Almudena. So please, it's over to you.
Thank you, Mahmoud and Bijim, and thank you for the invitation. I feel really grateful for being here for many reasons. I've been attending some of your lectures before, and I think that you're a great group and an example to follow. And I've been also, when I was beginning, I also attended a course in Virgin's hospital, in Evelina's hospital, and it's a very nice thing to be invited here to talk to this forum. And to begin with, this talk should be the second part of a talk that you will have in a few weeks' time about lung ultrasound in RDS, in preterm infants. And we would like to explain what can we use lung ultrasound for after the initial phase of RDS. And this is the guide that we will be following throughout this lecture, and we will begin talking about how can we know how does lung ultrasound progress after the initial phase of RDS. In the first lung ultrasound score was a semi-quantitative score that was adapted in the neonatal intensive care units to decide which infant would need surfactant administration. And as you could imagine, it is increased in the infants who have a more severe disease. It is more or less calculated in the following way. We have to evaluate different fields in each lung. And in each one, we see the grade of variation the lung has, depending on these 4 images. The one with a line, pleural line, a nice pleural line, thin pleural line with few B lines would give a score of 0. And if we have an increase of B lines, we will move to 1 or 2 when there's this coalescent B lines without being able to see A lines at all. And when we have big consolidations, then we reach to a number 3 in this score. If we zoom the value that we get in each field, different parts of the lung, then we get the final score that would range from 0 to different numbers, depending on the number of fields that we are evaluating. The most usual approach in terms of surfactant administration of first publications in very low birth weight infants was just including 3 fields in each lung, 2 in the anterior part of the thorax, upper anterior and lower anterior, and 1 lateral. So the range of this evaluation will go from 0 to 18. And with this background, in 2019, we published this paper in which we evaluated prospectively and weekly since birth how was lung ultrasound score changing from time in very low birth weight infants and dividing them according to the final diagnosis of BPD. And you can see that the first week of life, all infants show high lung ultrasound scores because they were in the initial phase of surfactant deficiency. But those that didn't have BPD had this sharp decrease afterwards with low lung ultrasound scores that remain almost in zero until the end of follow-up at 36 weeks post-menstrual age. However, those infants that did need oxygen for a longer time and finally get a diagnosis of BPD, they did have this high lung ultrasound scores persistently in time. But this evolution is not the same through all gestational ages. If we, this is a later publication in which almost 400 infants were included in more than 6 NICUs in Spain. And if we divided them according to gestational age at birth, we can see that the evolution of lung ultrasound score is more or less the same. This is in those infants with a final diagnosis of BPD in terms of oxygen at 36 weeks post-menstrual age. We have these persistently high lung ultrasound scores in both groups. But if we make a sub-analysis of only those that were born more immature and without a final diagnosis of moderate severe BPD, we can see that the infants born before 38 weeks have these persistently high lung ultrasound scores almost until 1 month of age, with a slow decrease afterwards. However, those born after 38, and mainly all preterm infants, will have an increased lung ultrasound score the first days, that then decrease and remain low for the whole follow-up. So this different evolution has to be taken into account when we are evaluating how the lung is progressing in this population. And also, if we analyze separately these two groups of gestational ages in terms of those that develop severe RDS that needed surfactant and those that didn't, you can see the smallest infants that didn't need surfactant in birth were born with lower lung ultrasound scores, but they also were increased afterwards. And this increase that remains high also at the same moment and for the rest of the weeks until 1 month is persistent in all infants. And this will be like the ultrasonographic description of what Dr. Van Kelary and Dr. Anajov described as respiratory instability of prematurity. This is an entity that will be like the continuation after RDS. Then we will have this disease, and then we will have a final diagnosis of BPD or not BPD at 36 weeks post-menstrual age. The smallest infants they are not able to like breathe by themselves alone. They need they have needs of non-invasive ventilation for a long time, and this entity that they call respiratory instability of prematurity will be what we are watching when we are performing lung ultrasound in this population. This disease could be explained by different physiopathological aspects, like lung injury due to oxygen the first days of life, overdistension during invasive mechanical ventilation, atelectasis, pulmonary overflow, or edema, muscular respiratory insufficiency, and whatever. And the thing is that we are able to see how the lung of these infants is progressing, and we will see now that this is important in terms of predicting BPD or decision to extubate a baby or removal or non-invasive ventilation. So knowing this, now we're going to talk about the practical issues that we can use lung ultrasound for. And the first one, and the one that we have more reference up to date, is BPD prediction. This will be an example of an extremely preterm infant born at 26 weeks, which is now 2 months of age. I think the videos are not moving because too many videos in this slide. But you can see that there are different degrees of variation in the different fields studied. This will be the representation of both left and right lung. And here you can see anterior lateral and posterior fields. And this is an heterogeneous disease with different grades of variation, with almost normal lung ultrasound here, an interstitial and severe interstitial alveolar pattern, and with huge consolidation in posterior fields. Too much for my computer, I'm afraid. I'm going to stop sharing and try to fix it. Sorry for this.
No worries.
Okay, here we are again. We were watching a few images of how BPD is using lung ultrasound, but we don't want to diagnose BPD when it's completely established. We want to predict it as soon as possible to try to assay different treatments or respiratory modified respiratory support or whatever, and to give a prognosis for the family, for example. And there's a few publications using lung ultrasound that have been done with this aim. But we have to change the way we evaluate the lung. And what we thought that maybe was more useful was not just evaluating anterior and lateral fields, which is what classical lung ultrasound does, but included also posterior fields on the lung, in which we know that the BPD has the more severe representation of the disease. And this is what some authors have called the extended lung ultrasound score. This is the first study that analyzed this, and they included more than 150 patients born before 31 weeks in different NICUs in France and Italy. And they evaluated seriously classical lung ultrasound score and extended lung ultrasound score indexed by gestational age, because we know the gestational age influence the evolution of lung ultrasound score. And they evaluated the lungs in these infants at the first day of life at 7 days, 14 days, and 28 days. And they saw that both scores progress differently in BPD and non-BPD patients, as you can see here, with a significant difference in all moments evaluated, and trying to get the diagnostic accuracy of these scores as soon as 7 days of life. You can see here the area under the curve for both values, and sensitivity, specificity, positive, negative livelihood ratio, and positive and negative predictive values at this cutoff values. You can see that the area under the curve of both scores is over 0.8, which is quite a good one. So this is something that we can use. And they also studied whether it's useful to use the extended lung ultrasound score in terms of predicting BPD. And you can see that there's a small difference between both scores in different moments evaluated, mainly in the first 2 weeks of life. When we get to a later evaluation, maybe it is really useful using extended lung ultrasound score, but not as soon as the day 14 of life. This group of authors from different NICUs in Italy, in another paper published a few months later than the previous one, also analyzed 141, the same number of patients born before 30 weeks. And they, as you can see, that the extended lung ultrasound score performed in the 7 days of life did have similar area under the curve as we've seen here. But the difference with this paper to the other is that they analyzed separately infants born after 38 weeks and those before and those born before 28 weeks, sorry. You can see that the probability of developing BPD was increased much higher in those born more mature. However, those born more before 38 weeks didn't increase their probability of developing BPD just with having high lung ultrasound scores, because we've seen that all of them had this increase of lung ultrasound score after the first days of life, although they finally don't develop BPD. And this is, they also depicted the same picture the same figure that we've seen before, in which infants born at 25, 27 weeks do have persistently high lung ultrasound scores that begin to decrease after 4 weeks and about 1 month. And these two papers and some others that were published just in a few years' time, because we were beginning, the first publication was 2020, now we are 2022. These publications were meta-analyzed last year in this publication, in which we have a pool sensitivity and a pool specificity for lung ultrasound score in terms of prediction of BPD of 0.70 and 0.78. That is good, but could be improved. So what can we do to improve BPD prediction in this population? Where we have different information from our babies, maybe combining them would be a better approach. And this is something that we did. This is multi-center Spanish trial with 6 NICUs that included 300 infants born before 32 weeks. And we created different models in terms of BPD prediction, only with very simple clinical variables like gestational age and birth, and sex. And if you add lung ultrasound score, the classical lung ultrasound score at day 7, you can see that the area under the curve could be improved. And it is improved to a similar level that if we included more other complicated variables that could be subjective between or different between one NICU to another, like for example, the need of invasive mechanical ventilation at day 7 or the diagnosis of a significant PDA. And we also replicated these results not at 7 days, but at 3 days of life. And you can see that also the simplest model can have an improved in area under the curve, just including the value of lung ultrasound score at day 3, comparing to other models like other subjective variables like the need of invasive mechanical ventilation at day 3. These results were also replicated by a Canadian group that also analyzed this simple model of BPD prediction, including gestational age or gestational age, sex, and the need of invasive mechanical ventilation of different moments. And finally, if we include lung ultrasound score, that you can see how the diagnostic accuracy of all models can be improved. So this is something that's growing day by day, and you can see that lung ultrasound score is a good tool that we can use to help us with the aim trying to detect the infants with high risk of BPD. And here I can show you, I'll show you a clinical scenario, an example how we do it. This will be a female, all these are real cases, a preterm infant born at 25 weeks with this birth weight. And she was born by vaginal delivery in a mother that was colonized by Uroplasma parvum, and she had a suspected chorioamnionitis. The girl was intubated at birth and received 1 dose of surfactant. And you can see now first ultrasound that she had at 4 hours after the surfactant. You see this will be anterior, lateral, and posterior field in 1 lung. You see this nice pleural line with lung sliding, few just no AB lines at all in anterior fields, 1 or 2 in lateral fields, and a few more posterior fields. This is quite a good lung, quite well aerated. But the patient really was doing good. She was stable with low FiO2, low respiratory settings, though we were unable to extubate her successfully. She also tested positive for Uroplasma parvum, so she received azithromycin for 3 days. but the ultrasonographic evolution was not that good. Here you can see at 3 days of life, the same fields. You see that the pleural line is not that thin, it's not that nice. We have some fragmentation in some areas, and we have an increased number of B lines with an interstitial or maybe alveolar interstitial pattern. And at 7 days of life, you can see how the thing is going with this blurred and thick pleural line with lots of fragmentations, wide lungs, although the patient was still on the same respiratory settings. This patient did have a very bad evolution with a severe respiratory disease, an increase in respiratory support after 2 weeks, and at 36 weeks post-menstrual, she was still on invasive mechanical ventilation with this FiO2, inhaled nitric oxide, corticosteroids, diuretics, and so on. So we have this exam, lung ultrasound, and we have a big, this has a big potential, and new reference and new bibliography is going on. So maybe we can use it in the future to try to decide which patient will benefit more of using corticosteroids in an early stage. The next issue we would talk about would be extubation failure. We're talking about after RDS, so there's no publications up to date about extubation failure in evolving BPD, I mean, after the first week of life. You know that many of our children are not intubated for that long, but some of them are, mainly those that have more risk of developing BPD. But we believe that we have to take into account not only lung ultrasound score, but also the existence of pre-extubation consolidations. And why do I say this? Because in this paper that I showed you before, we also compare lung ultrasound evolution and the need of invasive and non-invasive ventilation in infants according to gestational age. And we can see here that those that didn't develop BPD did have this persistently high lung ultrasound score that we explained before, but most of them were successfully successfully extubated when they still have high values of lung ultrasound scores, and more or less is the same what happens in those born at 26, 27. So maybe it's not just lung ultrasound score what we have to look for when we're trying to get which infant is the best candidate to have an extubation attempt. We performed this pilot study in 6 NICUs in Spain, and we presented it in the last session of the APS. And we got 50 infants born before 30 weeks, and we performed lung ultrasound 24 hours before the extubation attempt. And we saw that although all children had similar respiratory severity score, those that have an extubation failure did have higher lung ultrasound scores, but not quite not with great clinical difference with those that didn't. But they also had different numbers of consolidations in the lung ultrasound performed before the extubation attempt. And this is also interesting to see that if we divide the children in terms of how when did the reintubation occurred, those that had the intubation after 7 days or more, which are those that are not supposed to be due to a respiratory condition, maybe to a sepsis or surgery or whatever, they didn't have any consolidations at all compared with those that fail to a supposedly respiratory, to the respiratory disease. Combining all these variables to get a model that could help us predict the risk of extubation failure, you can see that infants, dividing infants according to gestational age, birth weight, and respiratory severity score, did have this blue line of area under the curve for predicting extubation failure that we can see here. And if we increase, if we add lung ultrasound score and the number of consolidations that these patients have before the attempt, we can increase the area under the curve significantly, which maybe in the future could help us to deal with this problem. This is an example of a 24-weeker we are evaluating just posterior fields in both lungs. This is upper posterior, lower posterior, and one lung and the other. And you see that she has a huge consolidation in both lungs, which maybe is not a good idea to have before an extubation attempt. If we change the patient's position and place it in prone, we can see how just in 1 hour's time, how the consolidations have been removed, and maybe the baby would have more chances of being successfully extubated in this moment. There's now a multi-center international study trying to get more clues in this issue, including all these centers, and maybe in a few years' time we could give more information about the use of lung ultrasound in this population and with this aim. Another thing would be talking about the optimization of ventilatory support. This is not very different to what we could find in the rest of ages, even in older children. I would like to give you an example of how we do it, although the lecture that Beijing did a few weeks ago was quite a good one. But here I can show you, I wanted to show you this girl that was born at 24 weeks, but with this birth weight, without respiratory distress at birth, but she needed to be intubated at 17 days of life due to a surgery. And she was stable in low respiratory settings, but then one day when we get to the NICU at 8 p.m., at 8 a.m., we find her with a peak inspiratory pressure of 19, FiO2 40%. So then we get lung ultrasound, we check her lungs, and we find this consolidation here next to the heart, here, okay, that we were able to alleviate just changing the patient position, increasing PEEP lightly, and replacing the tube that was not in the correct position. So we know that we can recruit this, or we can adapt the position or the respiratory settings of our patient according to lung ultrasound. But sometimes it's very useful to find these things also. This is an extreme examples, but these are two infants born at 24 weeks, different patients, in which in a routine lung ultrasound, we got this big atelectasis in both patients. Should we then try to, if they're doing good, if they're with low respiratory settings, normal gases, no respiratory distress, should we try to do something to remove this atelectasis or not? We don't know this yet. We know that we can. There's many publications, as we've heard in Virgin's talk, and recruiting maneuvers and all that in children under anesthesia and so on. But maybe we don't have to be that aggressive in very low bear infants, because we don't know the consequences that this atelectasis will have in this population. I'm talking about children with mild disease, not acute exacerbations, no baby with high respiratory settings, no babies with high FiO2. There's no publications of this, but I wanted to show you this this communication that we presented in a previous edition of the lunch meeting in Paris in 2020. And we trying to know whether if the existence of consolidations in this population did increase the risk of posterior developing BPD. And we analyzed 2,000 patients, and we divided them in more immature and more mature infants. Those born before 28 weeks had more frequency of consolidations in the follow-up. And although as most of them develop RDS, we decided to divide the moment when we find the consolidation and before and after 1 week. And those that have consolidations after this first week, but only in anterior lateral fields, were related to BPD. So maybe in this population, consolidations found in posterior fields when the baby is not on high respiratory support should not be recruited, or at least according to these results. And however, infants born after 28 weeks, did have less frequency of consolidations, but any location when you find it, and any time, any moment that you find them, are really related to BPD. So we have different populations with different diseases, different lungs, and we have to adapt what we find in lung ultrasound according to the patient that we have next to us. Does it mean that recruiting these consolidations are we reducing BPD? No, maybe it's not the point. Maybe this is something that we have to continue studying, but this is the evidence that we have now. And I also wanted to show you this paper performing adult NICUs in adult ICUs. These are adults after RDS, in which they were randomized to two groups. In the intubation group, the adults received treatment guided by lung ultrasound. I mean, physicians and nurses decided on the patient's position, on the need of nursing and whatever, according to lung ultrasound. And the control group not, they just have standard treatment. You see that there are smaller numbers, but the intubation group did have higher days of mechanical ventilation, high treatment, high time in ICU, and longer time of hospitalization. And those in the intervention group also have less aspiration events and less ventilator-associated pneumonia. So maybe in the future, we should be exploring all patients in the NICU with a lung ultrasound, and not just with auscultations. Maybe, we don't know the answer yet. Next issue, we'll be talking about NIV withdrawal. This is the only publication that appeared last year, in which the authors analyzed the power of lung ultrasound, trying to detect the NCPAP removal failure using lung ultrasound. And you see here that the area under the curve is quite good. They performed lung ultrasound before the first trial of NCPAP removal and after it, and using a cutoff value of 8 points in the lung ultrasound score that we've played before, did have this sensitivity, specificity, positive, negative predictive value, and positive, negative radio. So maybe this is something that we should also try to explore before trying to remove nasal CPAP or non-invasive ventilation in our infants. And how we do it. I was explaining before when we were talking about lung ultrasound progression in these infants, that this will be like the usual lung ultrasound pattern that we see in extremely preterm infants after the first week of life and without significant comorbidities. This will be an infant stable on non-invasive ventilation, and we see this persistently pattern of lots of B lines without thick pleural line, without consolidations. Where do we decide to remove nasal CPAP? Well, we have seen the publication before, but in our practical day-by-day basis, this is what we need to see before trying to remove non-invasive ventilation. We have, in this patient here, we have progressed from an alveolar interstitial pattern to just an interstitial pattern when we see just a single B line separated one from another, and we can see the existence of A lines. In this case, then we can begin to think that maybe this patient could have a successful attempt of removal, non-invasive ventilation. But this has not been proved. We cannot. I cannot show you. Strength of reference to support this recommendation, but you will have it in a few years' time. Next time, the next issue we were talking about would be about PDA and lung ultrasound. And as you know, PDA creates a situation of a pulmonary overflow in extremely preterm infants. And these 3 papers have analyzed the usefulness of lung ultrasound to monitor the amount of lung water in this population. And although they have different methodological issues, this is more or less reflected here in this figure, this is another paper talking about BPD prediction, but they also analyze lung ultrasound in patients according to the existence of a closed or patent ductus arteriosus. And you see how infants with PDA had higher lung ultrasound scores in the first week of life, but there's no significant difference after this. In this other paper that I showed you before, they also analyzed the evolution of lung ultrasound according to complications different from BPD. And they were PDA that required treatment, late onset sepsis, pneumothorax, or persistent pulmonary hypertension. Here you can see that the group that we are looking at now is the light gray. And you see how they remain on high lung ultrasound scores that begin to decrease at 4 or 5 weeks of age. And this is quite similar to this other graph in the same picture, that in the same paper that I've shown you before, in which you see that the smallest one began to decrease their lung ultrasound scores at about 4 or 5 weeks of age. So are we really watching the evolution of PDA, or are we watching the evolution of normal gestational age in this population? Can we use lung ultrasound to know how the pulmonary flow is in infants with PDA, or can we use lung ultrasound score to monitor lung water due to PDA in evolving BPD? We don't know the answer yet. There's a few studies with this aim running out, but we don't have preliminary results yet. We only have this article published 1.5 years ago, in which the authors analyzed the evolution of 5 patients that had percutaneous PDA ligation. And you can see that lung ultrasound scores decrease in the first hour after the ligation and remain lower 6 to 12 hours before. These were infants born at a median age of 25 weeks that had the ligation at about 1 to 2 months of age. So maybe you could use lung ultrasound to monitor lung water due to PDA, but we don't have consistent recommendations in this issue now. And last but not least, can we use lung ultrasound to see the response to medical treatments that we give to very low birth weight infants? Well, these are 3 cases that we presented in a meeting a few years ago, in which we analyzed lung ultrasound after the initiation of postnatal corticosteroids, different patients, different reasons for initiating the treatment. And you can see that all of them had this decrease of lung ultrasound scores after the initiation of treatment. And this will be an example of what we see. This is the lung ultrasound of whatever patient is, which is stuck on non-invasive ventilation, different failure attempts for removing non-invasive ventilation. This is the left lung on the right lung. We are always watching anterior, lateral, and posterior fields. And this is 2 days after the initiation of the treatment, the same patient. You can see how the lung has improved. We are always seeing a thin pleural line, but the number of B lines and the pattern has changed. We had a severe alveolar interstitial syndrome, and now we have an interstitial syndrome in all the fields studied. This is the left lung, and this is the right lung. Okay, and this patient, this concrete patient was able to be removed the non-invasive ventilation just 3 or 4 days later. So we can use lung ultrasound to monitor how the lung is doing after the initiation of a specific treatment, in which could have results on the lung. And this is another paper that we published a few years ago, in which we analyzed the effect of diuretics in the lung of very low birth weight infants. We divided them according to a clinical response in terms of removing or decreasing respiratory support after the initiation of treatment. And you see that those that had a clinical response decreased their lung ultrasound score just the very first day after the beginning of the treatment, and those that didn't respond did have the same lung ultrasound through the whole follow-up. This is another paper published last summer, in which this group analyzed not lung ultrasound score, but a score adapted and created counting the number of B lines that these patients' lung have. You can see that those patients that receive diuretics, so this decrease in this score, that didn't happen in those patients that didn't receive diuretics. So after this long lecture, I think that we have given some information and a revision of the evidence about these issues, and we can say that we have enough evidence to say that lung ultrasound is a good exam to predict early BPD and to optimize ventilatory support. However, we don't still have robust evidence to say that it can be used for extubation failure, NIV withdrawal, PDA in lung ultrasound, and to monitor response to medical treatments. But I think that with what I've shown you, then you can believe that maybe in a few years' time we could have more evidence and more information on these issues to say that we can use it also for this. I would like to thank my colleagues from Spain that have helped us with all these studies and collaborating with us, as well as other centers in different countries that also have been helping us with these issues. And first of all, thank you all for your attention and for your interest in this great topic. Thank you very much.
Thank you very much, Almudena, for this exceptional talk. I mean, we are very, very grateful because it's such a high quality talk, and you've been involved in all these research studies. I'm following you since we met in St. Thomas a few years ago, and all you brought to the lung ultrasound community is really amazing. I've got lots of questions, of course. I will see if anybody has a question first, or otherwise I will start. So maybe I start with the first question. I would like to know, which model do you practically use in your unit to predict BPD?
What do you mean, which model? Which lung
in
ultrasound?
In your unit, because you've shown us multiple models with a good area under the curve. So, for example, for the most immature population, for the one we are most interested, which model, on the one you've shown us, would you use to predict with the sex, GA, lung ultrasound at day 7, and I can't remember all the models, but are you using any of these?
I use lung ultrasound at 7 days of life, but as you've seen, the predictive ability of lung ultrasound as alone in BPD in the smallest population is not as good and as the biggest. So now we are recruiting babies to try to guess. I think, in my opinion, there's some other signs that are more specific in terms of prognosis of BPD, but not just lung ultrasound score. If you use only lung ultrasound score, it's not that good in those babies born before 28 weeks. So what I do is that I look for consolidations, fragmented pleural line, and things of bad prognosis in lung ultrasound, and not just the value of lung ultrasound itself alone. However, in the biggest ones, in those born at 29, 30, if you see high lung ultrasound score more than just 7, 8 at 7 days of life, you know for certain that the baby is developing BPD.
And I remember in one of your publications, you compared the value of your models with sex, GA, and lung ultrasound score day 7 with the NICHD model, which is based only on demographic and characteristic of the patient. I think they include the GA, birth weight, sex, race, postnatal day, ventilator type, and FiO2. And you say actually it was quite comparable to this score. So how do you comment on that?
Well, in my opinion, that model has been created in a different population to ours and has some variables that are subjective. I mean, maybe the same patient is not managed the same in my unit as in another unit. So if we could use variables that are not just subjective, like the need of invasive mechanical ventilation or the value of FiO2, that also give us more clues or more help us to decide which infant really is developing BPD or not. Because an infant who could have high FiO2 due to many reasons, not only their respiratory support. And in my opinion, if you just need sex, gestational age, and lung ultrasound, which is quite reproducible between different examiners, then you have the best choice or the best tools to decide the risk of BPD in that population. The next step will be to know whether, if using these exams, we can say different treatments for trying to reduce BPD. That will be like the next step. Now there's nothing we can do about this. We don't know whether if using corticosteroids or not in this population, but that will be the next step, to try to assay different treatments according to lung ultrasound or according to clinical vitals and lung ultrasound.
Thank you. Mahmoud.
Thanks, Almudena. That's what was fantastic. So just I've got many questions, but I just want to give the opportunity for others as well. So just a quick, simple question. We could see that we don't have a robust kind of recommendation for extubation failure prediction. However, I know you're also doing diaphragmatic ultrasound. Have you thought to incorporate that along with the lung ultrasound score, and also looking for consolidation?
Yeah. You mean, do I do it in my unit or studying it? Oh, yes, of course. Yes, we always, you know, I haven't shown you the publications. There are about 4 publications using lung ultrasound after the initial phase of RDS in the first days of life. And when you find an alveolar interstitial pattern, you know, called SMB lines or consolidations, then it's better not to extubate that infant, although he or she is in low respiratory support, because they have high chances of failing. So that's what we are doing. After that, after the first week, when the infant is not as good and probably is developing a BPD, then we try to find that the patient don't have consolidations and have at least, if possible, thin pleural line with low respiratory settings, and then we try to extubate them.
But you don't use the diaphragmatic ultrasound, like the diaphragmatic excursion, and see if that's kind of sort of readiness for extubation, if you know what I mean?
Yes, well, we don't do that because well, there's one paper exploring this issue, which has, in my opinion, some methodological issues that could be improved. And when you use the excursion, you have to place the patient on pressor support on CPAP mode, because if not, what we are watching is the movement of the diaphragm due to the IMV, not the proper diaphragm itself. No, so in my opinion, diaphragm ultrasound is not as good. I don't have robust clinical data to demonstrate this, but it's not as good to detect the infant that who have an extubation failure. I've tried many times and didn't see it as good as we may think, I'm afraid.
That's great, thank you. I think Sujit.
Hi, Dr. Alonso. Thank you so much for your talk. I've learned quite a lot. I had a question. I had a couple of questions. One was with regards to the BPD prediction. When you do, I know you've said that you don't just rely on the lung ultrasound score, but I wanted to find out how well you'll be able to tease out the effects of the duct very early on. And you know, teasing it out from the underlying lung parenchymal disease. Is that possible?
We are presenting an abstract in PDAs this year in Washington, because we believe that the most immature infants, as you've seen, do have high lung ultrasound scores, irrespective of whatever the state of the PDA is. So you would see the same pattern in these infants, although they have a PDA or a closed ductus. I don't know if I understood, if I say correctly. these infants will have higher lung ultrasound scores, whether they develop BPD, whether they have a PDA or not. So the smallest ones, we cannot monitor lung water using just lung ultrasound if they have a PDA or not, because the signs are the same. You are watching hypoventilation, you're watching lung edema, and you cannot say if that's because the evolving BPD or PDA or both. So you cannot differentiate this in the first weeks of life. I don't know if that's answered your question.
No, that is useful. I had another question. In your practice, are you using routinely, I know you've mentioned a paper about CPAP withdrawal, but are you using lung ultrasound to wean off high flow nasal cannula support?
No.
So you're not using that?
No.
Okay. Thank you.
Thank you.
I don't think there's any other questions, so I will just ask my other question maybe. As you know, I really feel that the lung is not only parenchyma, and with the lung ultrasound score, what we're exploring mainly is the alveoli, the bronchus, but we're not exploring the vascular part enough, I think, maybe with the B lines, with the interstitial edema. So I'm sure you have thought about it, but how would you incorporate some hemodynamic parameters into your score to optimize the prediction in the most immature babies? I know the team of Yasser have looked at the eccentricity index at the flow in the pulmonary artery. We're not predictive for failure, but do we have, I'm sure you have thought about it, so tell me what you think about that, including some hemodynamic parameters in your score.
Yes, that's quite a good idea. Yes, we are doing this. As I told you, we were now analyzing different signs in lung ultrasound, not just lung ultrasound score. And one of the things that we are evaluating is just not the lung, but also the heart. We are evaluating the eccentricity index, the relationship between the size of right and left ventricles, and the other one was, the TAPSA. And with these three, we tried to get heart ultrasound measurements that were able to be performed, but not profit heart examiners. You know, that's lung ultrasound is more easy to learn, but maybe those that perform lung ultrasound are not able to perform advanced heart ultrasound as well. So we're trying to get different, measurements that could be performed at the bedside, but someone that's not an expert in heart ultrasound. And this is something that we are analyzing. We don't have the results yet. We try to combine heart variables with lung ultrasound to try to predict BPD in a paper that we published also last year, I think. And we got the both measurements were in parallel and didn't get much value to combine them together. We know what happens with heart ultrasound, but from the moment, this is what we got.
Okay, thank you. Mahmoud? We have 4 minutes left.
Okay, sorry. Just see if anyone else has question. If not, I will just a quick question. I was really interested just to see, obviously we are in our group, we're trying to promote for lung ultrasound. I just wanted to hear from you your thoughts about implementing that. And do you have like a local guideline in your unit when to use lung ultrasound in those babies? Do you use it routinely or few people only, those kind of things? Well, my unit's not that big as maybe yours, and we only have 15 beds in NICU. So just when the baby is more or less stable, we try not to perform daily lung ultrasounds because we won't get much information for that, and the manipulation of the baby maybe is not as good and could get them some stress. So in the first days of life, we try to perform it on always before surfactant administration, maybe the day after, but afterwards we try to do it every 3-4 days the first month, and then weekly. And when usually the attending neonatologist is the one that's performing lung ultrasound, but if not, I always try to do the exam when
when the attending physician is not available. The thing is that you have to incorporate it in your clinical practice, because when you are going to explore the infant and the nurse going to change the infant position, you warm the gel a few minutes afterwards, and then you do it together with the nurse, and it will be just about 2 minutes time. It's not stressful for the patient, and it's give you much more information than just the auscultation alone.
Yeah, that's brilliant. Thank you very much.
Any other question in the audience? I know we're a bit impressed. Yeah. So maybe I have a last one and then we might close. Of course, I was very interested by what you said about the location of the consolidation before and after 28 weeks, because I think it's remind us about the talk of Daniel Lichtenstein about the focus he has on the anterior part of the lungs, saying that these abnormalities seen in the anterior part of the lungs are really something, it's a message for us that something is abnormal, it's a pathology, where when you see them in the back, it's much less meaningful. And I wonder, because I had the feeling that many of these the sickest baby have consolidation in the right lower anterior part of the lung, which is probably the highest one. And I was always very worried by the one who had already consolidated this area. So my question is, did you look specifically at, are some areas anteriorly more predictive of BPD than others? No. And second, about this consolidation, would the characteristic of this consolidation, recruitable, non-recruitable, the size, would it be worth including this characteristic into the score?
Yes, no, we haven't explored that. That's very important. I think will be very useful to perform a study with that. The thing is that most of our patients are stable enough so as to have a lung ultrasound, but a non-expert examiner. So most of them were patients stable with not very high respiratory support, and you perform lung ultrasound and you find a consolidation. Does this increase the risk of BPD? We wanted to demonstrate that what you were saying, it's very usual to find consolidations in posterior fields that didn't have a meaning in this population, that they're at long time ventilated. We are not studying this in the sicker ones.
Thank you, Mark. And the last question, and then we're closing because it's 2 o'clock.
Hi, thank you for excellent talk. Mark Attach from Aberdeen here. I noticed that some of your studies aggregate patients from different sites as well in Spain. So how do you ensure that, you know, the way they are doing lung ultrasound is consistent and the way they're scoring? Do you have like guidelines in place or flow charts? Thank you. Excellent talk.
Thank you very much. Between different NICUs or between different patients?
Between different NICUs?
Yes. Yeah. Before a new NICU enters our group, we perform like a test. We have some images that we send them, and we check the value of lung ultrasound that they get. And in our papers and some others, we always perform inter-agreement performance with different exams, and all of them are quite good. It's very easy thing to decide between 0, 1, 3. It's not that as performing a heart or observable ultrasound, which will be more difficult for a non-expert examiner.
I see. Thank you so much.
Thank you very much.
Thanks a lot, Almudena. I don't know how we can thank you more.
I am the one that's grateful. I am the one that's grateful for being here. I would like to have a group as collaborative as yours in my country. Congratulations for that.
Well, that's Mahmoud leading on that. So
thank you. It's a teamwork where, we're very fortunate to have those people around. So I'm sure we're going to invite you for another talk later on. So thank you very much for your time, and thanks everyone for joining today.
Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye, Almudena.
Bye. Thank you.